My dear students, in this video, I am going to discuss about diaphragm protective ventilation. We generally talk about lung protective ventilation. We also talk about brain protective ventilation. But something which is different and yet related to lung protective ventilation is diaphragm protective ventilation. And there are considerations for diaphragm protective ventilations, particularly in patients who are on ventilation for a prolonged period. And there are certain concerns. There are certain overlapping features with lung protective ventilation, but there are some distinct features as well. And we need to understand them for safe mechanical ventilation of our patients. Because finally, it is not only the aim of mechanical ventilation to restore the functioning or the primary condition, but also to reduce iatrogenic damage during the process of mechanical ventilation. Let us start with this case. A 55-year-old man with severe pneumonia and septic shock is on day 2 of ICU admission. He was intubated for acute hypoxemic respiratory failure with a PF ratio of 120 on FiO2 of 0.6. He is on volume control assist with the settings of tidal volume at 6 mL per kg of predicted body weight, respiratory rate of 24 per minute, PIP of 10 centimeter of water, FiO2 of 0.5, inspiratory time of 0.8 seconds, plateau pressure is measured to be 26 centimeter of water, and the driving pressure is 16 centimeter of water. Now, this patient is receiving moderate dose norepinephrine for shock. Sedation is with propofol and fentanyl. The RASS score is -4, and there is no visible respiratory effort. Over the past 24 hours, his gas exchange has improved slightly, but it is noticed on the ventilator that he has been fully controlled with no assisted breaths. On performing a diaphragm ultrasound, there is thin diaphragm with minimal thickening during inspiration with a thickening fraction of about 8 to 10%. Now, what should be done to protect diaphragm and prevent ventilatory-induced diaphragmatic dysfunction? In order to explain the process, we have to understand the core concept of diaphragm protective ventilation by realizing that mechanical ventilation injures the diaphragm in two opposite ways. The first way is because of very low or zero effort of the patient. This causes rapid disuse atrophy and weakness, which finally leads to ventilator-induced diaphragm dysfunction, VIDD in short. Also, there can be damage because of very high effort. Now, this high effort is also causing the damage when we call it the patient has a high respiratory drive or SILI, which is the outcome. Because of this, apart from that cause, wherever there is very high effort on the part of ventilator, also there is overload related biotrauma and fatigue. And this also leads to weakness and prolonged weaning. So both very low or zero effort and very high effort can cause diaphragmatic injury. So diaphragm protective ventilation aims to keep inspiratory effort in a moderate physiological range while limiting the lung stress and strain. And this is indicated by the tidal volume, the driving pressure, and the plateau pressure. Now, this was published in American Journal of Respiratory Critical Care Medicine in 2020, and there they tried to segregate these two aspects while understanding lung and diaphragm protective ventilation, in which diaphragm protective ventilation was defined as a way of setting the ventilator so that the diaphragm keeps working enough, but not too much, to avoid both disuse atrophy and injury from excessive effort or excessive pressures, we will call it, while still respecting the standard lung protective limits. So within the lung protective limits, we also have to ensure that the diaphragm keeps working. So this mechanism of injury to the lung and diaphragm during ventilation is often interspersed because there are a lot of common factors which can cause injury to the lung as well as to the diaphragm. For example, if you see this circuitous diagram from the same article, we can see that breathtaking dysynchrony, excessive PEEP, insufficient PEEP, excessive ventilator assistance, they're all responsible for increasing the lung stress and strain. And whenever there is lung injury, there will be ventilator-induced lung injury. It takes the shape, the villi assumes the shape of the lung injury. On the other hand, if there is excessive sedation, excessive PEEP, then expiratory dysynchrony. So these are the causes which can lead to insufficient respiratory effort and drive, which can lead to longitudinal atrophy. That is called expiratory myotrauma in patients with excessive PEEP, or over-assistance myotrauma in patients with excessive sedation, which is because of diffuse atrophy. And so as you can see in your right-hand side of the screen, the diaphragm dysfunction and the lung injury, there is an overlap between certain factors, as you can see on the top, excessive ventilator assistance and excessive sedation. So there are both maybe lung stress and strain, and there is diffuse atrophy when we look into this part of the clock. As we go down here also, if we see that insufficient ventilator assistance, insufficient sedation, that can also cause baby lung stress and strain, atelectic lung stress and strain, and load-induced diaphragm injury. So at both instances, when in 12 o'clock position and in the 6 o'clock position, that is whenever there is excessive ventilator assistance and excessive sedation, or when there is insufficient ventilator assistance and insufficient sedation, there is a chance of both lung as well as diaphragm injury or dysfunction. On the contrary, if you look into the 3 o'clock and the 9 o'clock position of this chart, so either because of excessive PEEP, excessive dysynchrony, or insufficient PEEP, we can see that there can be either purely lung injury or purely diaphragmatic dysfunction. So that is why we say that this diaphragmatic dysfunction and lung injury, although they go hand in hand, there are certain factors which may be responsible for distinct damage to the diaphragm or to the lung. And this circuitous diagram is a somewhat a scientific explanation to at least some of these factors. So the conceptual framework for lung and diaphragm protection, now we know the causes of injury and the causes of strain, and is that whenever we look for 4 stages. One is the respiratory hemostasis, where we try to avoid dangerous respiratory acidosis while maintaining adequate oxygenation. In the second stage, we try to go for lung protection, where we try to minimize the cyclic lung stress, avoid excess regional stress from excess respiratory muscle effort, and avoid breath stacking dysynchrony. In the next phase, we look for diaphragm protection, where we maintain modest respiratory effort, avoid excessive respiratory effort, and maintain expiratory synchrony. And finally, all of this, when maintained, leads to improved patient outcome, that is relief from dyspnea, accelerated liberation to prevent nosocomial complications and ICU-acquired weakness, reduced mortality, and enhanced long-term functional status and quality of life. Now, if we see these steps, the conceptual framework, we have to that in order to reach the final improved patient outcome, we have to go through these 3 processes of respiratory hemostasis, lung protection, and diaphragm protection. So the commonly proposed diaphragm protective ranges include a tidal volume, which is similar to lung protection. Tidal volume ranges of 4 to 8 mils per kg of predicted body weight, provided the driving pressure remains below 15 centimeter water and the plateau pressure is less than 28 to 30 centimeter of water. But esophageal pressure swings. This is something which is more important and which is not there in lung protective ventilation. The swings in the esophageal pressure during phases of inspiration and expiration should be 3 to 15 centimeter within that range. Estimated inspiratory muscle pressure, or PMAS, roughly 5 to 10 centimeter of water. Airway occlusion pressure, about 1 to 4 centimeter of water, indicating neither very low nor very high drive. And diaphragmatic thickening fraction on the ultrasound, about 50 to 30% during the inspiration. So these are the commonly proposed diaphragm protective strategies or ranges that we need to follow. So in order to go an algorithmic approach, it is suggested that we have to measure the occlusion pressure. As I have mentioned you, the airway occlusion pressure should be in the range of 1 to 4 centimeter of water. And by measuring the occlusion pressure, we can the calculated predicted transpulmonary pressure, that is the inspiratory pressure minus 2/3 of the occlusion pressure, that will give the predicted transpulmonary pressure. And if it is less than 22 centimeter water, the lung stress is less likely. If it is more than 22 centimeter of water, lung stress is more likely. So when the lung stress it is less likely, lung stress is likely to be low, we estimate the respiratory effort with the occlusion pressure. So, and if we see that the occlusion pressure due to respiratory effort is less than 7 centimeter of water, we consider reducing level of sedation and or lowering inspiratory support. If it is between 7 to 15 centimeter of water, we see like the patient is likely within proposed safe limits for lung stress and respiratory effort. If the occlusion pressure with respiratory effort is more than 15 centimeter, then it is under assistance. So we have to consider increasing the respiratory support. On the contrary, if we estimate the respiratory effort with occlusion pressure and see that it is less than 7 centimeter in patients who are having an occlusion pressure of more than 22 centimeter or the calculated predicted transpulmonary pressure of more than 22 centimeter water, and with 7 to 15 and more than 15. If it is less than 7, it indicates over assistance. If it is between 7 to 15, you have to consider reducing the inspiratory support and or increasing the level of sedation. If it is more than 15, you have to consider increasing level of sedation. Now, this may not appear very simple because always we are not measuring the occlusion pressure, but once we measure the occlusion pressure, then it is possible, because most of these newer ventilators, it is possible to measure the occlusion pressure. If you measure it, then we will be also, it is possible to see the respiratory effort and see the changes of occlusion pressure with the respiratory effort. Now, how to implement bedside? So these are some of the advanced things. While implementing at the bedside, we have to prefer assisted modes like pressure support, assist control with spontaneous triggering. All these modes should be used when the patient is stable to allow at least some diaphragmatic activity instead of deep paralysis, and this should be done early. Then adjust the support, that is pressure support level or inspiratory pressure in assist control ventilation to keep the respiratory rate, the esophageal pressure swings, and the occlusion pressure in the moderate effort range, avoiding tachypnea and avoiding very high swings. Optimize the PEEP and trigger cycle settings to reduce dyssynchrony, like double triggering, reverse triggering, missed efforts, all has to be optimized, and because they are associated with both lung overdistension and diaphragm injury. Titrate sedation to allow comfortable spontaneous breathing with synchronous interaction instead of either deep suppression or an agitated high drive breathing. This is also very important. So if we follow these 4 steps, preferred assisted modes, adjust support, optimize sweep, and titrate sedation, we will be able to easily initiate diaphragm protection at the bedside of the ventilator. Now, next important thing is to monitor the effort and the drive, because the patient has swings, the patient's pathology changes. Sometimes the patient deteriorates after initial improvement. So monitoring is very important so that appropriate changes in the settings can be also performed and initiated and performed. So at the bedside, the possible tools to monitor diaphragm effort include esophageal manometry, which can measure the change in the esophageal pressure and estimate the inspiratory muscle pressure and the transpulmonary pressure. Airway occlusion maneuvers to estimate muscle pressure using transient occlusion tests. So the PO1 that is read from the ventilator is a quick index of the neural respiratory drive. And of course, the diaphragm ultrasound to track the thickness over time, fractional thickness over time, and detecting early atrophy or excessive loading. So regularly integrating these matrices with standard lung protective parameters like tidal volume, plateau pressures, driving pressure, gas exchange, hemodynamics. This is central to the combined lung and diaphragm protective ventilation. So if we try to look into the distinct aspects of the lung protective focus and the diaphragmatic focus, we know that in lung protective focus, our main aspect, the main injury to be avoided is the over-distension leading to villi. In diaphragmatic protective focus, the main injury to be avoided is atrophy and load-induced myotrauma leading to ventilator-induced diaphragmatic dysfunction. The key targets in lung protective focus is a tidal volume, which is in the lung protective range, 4 to 8 mils per kg of predicted body weight, a driving pressure of less than 15, and a plateau pressure of targeting of between 28 to 30, less than 28. In case of diaphragmatic focus, we have the esophageal pressure swings, so between 3 to 15, the occlusion pressure of 1 to 4, and a fractional thickening of inspiration is of 15 to 30%. The role of spontaneous effort is often minimized in severe ARDS in lung protective focus, but in diaphragmatic protective focus, it is actively preserved in the moderate range. We want that the spontaneous effort should be there, and its role is important to prevent the ventilator-induced diaphragmatic dysfunction. And regarding sedation or neuromuscular block, in lung protective focus, we always use more liberal use of sedation and neuromuscular blockage when needed for the lung goals. But in diaphragm protective focus, we have to use them cautiously, and aim is to avoid prolonged inactivity of the diaphragm. Here is an important point that if one cannot meet both lung and diaphragm targets simultaneously, like severe ARDS leading really low tidal volume and high sedation, the current evidence suggests that lung protection still takes priority over diaphragm protection. So after having understood this core concept, if we go back to our case, like I'm going back to the case, this 55-year-old man, severe pneumonia, day 2 of ICU admission, intubated for acute hypoxemic respiratory failure on volume control ventilation with moderate dose of norepinephrine with a RAS score of -4, and over the past 5 hours showing a gaseous exchange which has improved slightly, but with no assisted breaths noticeable on the ventilator, and a diaphragm ultrasound showing a thickening fraction of 8 to 10%. In such a patient, if we go stepwise manner, the first step is to restate the problem and the priorities, where moderate ARDS with good lung protection strategy is already in place, deep sedation with no effort and low diaphragm thickening fraction suggesting early disuse and the risk of VIDD. So this patient has a high risk of VIDD. So priority is to keep the lung protection with low tidal volume, low plateau and low driving pressures, but reintroducing some safe, spontaneous effort and avoiding excessive drive. So in order to do that in the step 2, you have to check readiness to light and sedation. Before changing anything, we have to confirm that it is safe to allow spontaneous breathing. Hemodynamically, the norepinephrine requirement is stable, is not rapidly increasing. There is no active myocardial ischemia. There is no severe arrhythmias. In oxygenation, the PF ratio is improving or at least stable, and FiO2 is less than 0.6 with no severe acidosis. The neuro status, there is no raised ICP, no neuro contraindication to effort like poor compliance of brain injury, etc. So if these are acceptable, the plan of sedation weaning trial with close monitoring has to be initiated. In step 3, we have to prepare monitoring for effort and safety. Ideally, we set up a monitoring before we lighten the sedation and see the diaphragm's response. 1, the ventilator waveforms. Look for signs on the high drive like short expiratory time, double triggering, big negative deflections. Then we look for the diaphragm ultrasound. We already have the baseline, that is the inspiration, it is 8 to 10%. Repeat after changes, we have to target it to 15 to 30%. If available, esophageal balloon or airway occlusion tests to estimate the inspiratory muscle pressure and the occlusion pressure and the changes of the occlusion pressure with the expiratory or with the respiratory effort, whereby we should be able to target a moderate effort range. So we should have a clear threshold at which we can abort or step back. Like if we have severe dysynchrony, if the plateau pressure rises more than 30 or a very high estimated effort, we have to step back. In the next step, we have to lighten sedation gradually, like reduce the propofol infusion stepwise by 25 to 30% at a time, aiming to move RAS from -4 towards -2 to 0 over 30 to 60 minutes. Maintain analgesia like with fentanyl to avoid pain-driven tachypnea and high respiratory drive. And reassess RAS, reassess the vital signs, the respiratory rate, the ventilator graphics every 5 to 10 minutes, at least in the early phase. So once the patient is awake, get the patient awake enough to trigger breaths, but not agitated. So a calm, cooperative, asynchronized state usually corresponds to a RAS score between -2 to 0. Next step, in the step 5, we allow and assess spontaneous effort, and this can be done in the same mode, that is the volume control mode, if it was a volume control assist, or the patient can be switched to an assisted mode once if the patient was on pure volume control, once the effort appears. So we watch for the patient trigger breaths. If there are small negative deflections in the airway pressures, change in the flow curve, and the respiratory rate matching the patient's drive, that indicates the patient triggered breaths. Monitoring the tidal volume, keep around 6 mils per kg with the predicted body weight. If the effort drives towards 8 or 9 mils per kg, that suggests high effort, and that is a risk to both the lungs and the diaphragm. Next, we check the gas exchange. In mild rise in PCO2 and slight dyspnea is acceptable if the pH stays more than 7.25. So permissive hypercapnia is allowed. So repeat this diaphragm ultrasound after patient has been breathing spontaneously for 15 to 30 minutes to remeasure the fractional thickening at inspiration. In step 6, fine-tune the support to keep the support of a safe zone. So this is the most difficult step because sometimes the efforts may appear too low. That is, the respiratory rate is between 10 to 12 with minimal negative swings. The fractional thickening still less than 15%. In those patients, we have to consider decreasing sedation a bit more towards the RAS of -1. If the patient is in the pressure support mode, slightly reduce the pressure support to make the diaphragm work more while preventing tidal volume from failing to be below 4 to 5 mils per kg. And we also have to recheck the respiratory rate, tidal volume, and the fractional thickening of the diaphragm after each change. Sometimes the effort appears too high. That is, the respiratory rate is more than 30 with big swings, double triggering, tidal volume exceeding 8 mils per kg, or strong paradoxical movement. Increase in those patients support slightly by raising the pressure support 1 to 2 centimeter in pressure support, or increasing inspiratory pressure with assist control, aiming the tidal volume back to 6 mils per kg and the respiratory rate of less than 30 per minute. We have to retitrate sedation modestly if agitation or high anxiety is driving the effort, or we have to consider adjusting the PEEP and the cycling criteria. That is, at what percentage of the flow, expiratory flow, the switches from, that is the expiratory trigger threshold if there is persistent dysynchrony. So in patients of pressure support, we have to change the flow cycling. So the bedside goal is a moderate respiratory rate, say low to mid 20s, tidal volume of 4 to 8 mils per kg, synchronous breathing, and a fractional thickening during inspiration of 15 to 30%. The next step, or the step 7, is to keep the lung protection non-negotiable throughout. We have to recheck the lung protective parameters after each adjustments to see whether the tidal volume is staying between 4 to 8 mils per kg of predicted body weight, plateau pressure remains less than 30, and driving pressure less than 15. SpO2 and PO2 are acceptable at the rates of FiO2 and PEEP with no signs of severe dynamic hyperinflation or barotrauma. Now, this is important because if spontaneous effort consistently pushes the tidal volume or P-plat above the targets, despite adjustments, we may need temporarily, we have to deepen the sedation once again, accepting shorter periods of diaphragm inactivity to prioritize the lung safety. The same thing I have told before, that out of 2, the lung protection gets priority if one out of two has to be selected. The step 8, we have to reassess over the next 24 hours. We document the ventilator settings, the tidal volume, respiratory rate, the P-plat, the driving pressure changes, the RAS, presence of dysynchrony, and the fractional thickening during the inspiratory phase, at least in every shift. If the patient remains stable with moderate effort, we can gradually move towards the spontaneous modes, like higher proportion of time on pressure support, preparing for weaning. If diaphragm ultrasound shows progressive thinning, or the TFDI remains less than 10% despite attempts, we have to discuss with the team whether sedation or modes of strategy needs more aggressive change, or whether we have to consider more advanced monitoring like esophageal manometry if the same is available. So my take-home message at the end would be that diaphragm protective ventilation means preserving moderate spontaneous effort while keeping lung protective limits for tidal volume and pressure. Completely passive ventilation causes rapid diaphragm atrophy and weakness with prolonged weaning. Excessive respiratory drive and effort can also injure the diaphragm and worsen the lung stress. The bedside goal is a physiological sweet spot of tidal volume of 4 to 8 mL per kg predicted body weight, low plateau driving pressure, comfortable synchronized breathing with visible but not labored effort. Achieving this requires dynamic adjustment of mode, support level, and sedation, and of course, guided by waveforms and diaphragm ultrasound. Thank you very much.